Hi everyone. So my name's Cody. I'm an R1 here in Ottawa in ophthalmology, and it's a real pleasure to be giving you all this talk today on ophthalmology in preparation for your LMCC. Congratulations on being all done CARMS interviews. I know this time period between interviews and match day can be, stressful and it seems very long, and so hopefully we can provide some distraction for that over the next 2 hours, discussing some topics in ophthalmology as it is relevant to the LMCC, and hopefully even to just your general practice as a physician as well, because these issues are very common, and regardless of what specialty you're in, there'll be ophthalmology issues that you come across. And so the next case I wanted to touch on is an 85-year-old gentleman who comes into your office with decreased vision over the past couple of years. And I think this case highlights something that's really important to elicit on history, is whether the patient describes central, peripheral, or diffuse vision loss. Many times, because your central vision is what you pay attention to the most often, patients won't really appreciate the difference until you ask specifically about it. And so when you're taking a history, I think it's important that you ask specifically whether this is an issue that's affecting their very central vision and whether the area around it is still normal. In this case, as you can see, when you ask, this patient has specifically central vision loss with normal vision surrounding it. The other thing that's important to touch on in this case, which we'll discuss on in a second here, is that this patient also has distortion in the middle of his vision. So if you were to hold up that grid there, the patient would describe the lines becoming wavy, even though objectively he knows that it should be a straight grid. In this case, he also notes a sudden decrease in vision in one of the eyes, for which he now has a central blind spot. And on your otherwise review of systems, he doesn't have any other symptoms like pain, headache, things of that nature. And so this is a very classic story for a condition that we see very commonly. It might be like the second most common condition we see after cataract. And this is something called age-related macular degeneration. And so this is another age-related condition that affects the macula, which, if you remember your anatomy, is the very central part of your retina where you see and use for your central vision. And so this is a degenerative condition where you essentially get waste products, which we call drusen, building up under the macula, which can result in the macula not working as well, and over time starts to degenerate. This is one of the most common causes of irreversible vision loss in the developed world. And in the early stages, because those waste products are just collecting underneath your macula, which is supposed to be a very flat surface for you to focus light on, it starts getting a little bit bumpy. Which is why in early stages of the disease, you'll get distortion of lines. And one of the ways we actually get patients to monitor age-related macular degeneration, or AMD, is to look at an Amsler grid. So they actually keep that grid on their fridge or somewhere where they see frequently. And they know to book an appointment with us if they start noticing some of those lines becoming distorted. And so it's a very common condition we see. Why this is important is because AMD can be classified into two main types. The first type is called dry AMD, which is by far the most common version and is the more mild version. And that just means you have those waste products building up underneath and you start to develop this distortion. And in very severe forms, you can start to develop complete vision loss in the central part of your field. The main thing that we want to prevent or get on top of very urgently is progression to something we call wet AMD. Which is when the macula degenerates to the extent that you actually start getting blood vessels forming in the macula where they're not supposed to be. And these blood vessels, as similar to neovascularization in other areas of the body, these blood vessels are very leaky and can cause bleeding in the eye within the layers of the retina. And this can be the cause of a very rapid and progressive irreversible vision loss. And there's there's a couple of options in terms of treatments for this, which is why if we think someone has progressed to wet AMD, they're seen very urgently, and we want to get on top of this condition because it can progress quickly. I think it's important to know some of the risk factors associated with AMD. So the sort of classic risk factors that we think about are age-related. Typically, these patients are Caucasian in ethnicity, and smoking is known to be a significant risk factor. So moving on to another case now. You see a lady that same lady in the previous case with the posterior vitreous detachment, but now she's having flashes and floaters in the other eye. And the handover you get from the emergency physician who saw her initially is that she now has this black curtain coming in from the periphery of her vision, coming into her line of sight. Aside from this, she didn't have any previous trauma, no pain to this eye. This has never happened before. And so, this is a very classic story for a retinal detachment, which is a condition that is also urgent in terms of ophthalmology referral, and basically refers to detachment of the retina from the underlying epithelial layer, which attaches it to the sclera of the eye. There's many different causes for retinal detachments that are beyond the scope of this discussion in terms of the LMCC. But sort of the most classic ones is when you have vitreous detaching from the eye, such as what happens with a PVD, you can get pulling on the retina itself, and that can result in a tear and ultimately detachment of the retina. But from a primary care or an emergency medicine perspective, if you even suspect a retinal detachment, which is classically known as this black curtain coming in from the sides of the vision, this regardless warrants an urgent ophthalmology referral. There's a number of risk factors we ask about typically for these patients. So myopia, which is nearsightedness or elongation of the eye, can predispose you to retinal detachments because your retina is under a bit more tension because the eyeball itself is longer. Or patients who have had posterior vitreous detachment in the past, which means that jelly in the eye is now pulling on the retina. When you see a patient with suspected retinal detachment, as we've established earlier, it's important to take your ocular vitals for these patients, so establishing what their vision is. This is particularly important because in ophthalmology, we classify retinal detachments into whether we think the macula is intact or the macula is detached as well. And so patients who retain good central vision, but we think have retinal detachment, that's a much more time-sensitive consult because we think that the macula is still attached, which means that there's actually a really good chance of having good visual recovery if we're able to intervene early, versus if the macula itself is off. Once the macula comes off, the chances of having good visual recovery is significantly lower, and that actually becomes a less urgent issue to deal with just because the chances of being able to repair central vision at that point is a lot lower. Beyond the scope of this lecture, there's many different ways that we treat retinal detachments depending on what the underlying cause is, where the retina is detaching from, and things like that. But all this to say, if you even think a patient has a retinal detachment, it's important to get in touch with your friendly neighborhood ophthalmologist on call. And so this case is a 68-year-old gentleman who reports gradual double vision over the past couple of months. And so this is a very common consult that we get, and will often firstly present to their family physician. So it's important that you at least have somewhat of an approach to how to manage this complaint. And it's also important because sometimes double vision can have life-threatening causes, so it's important to be able to pick up on some of those. The most important question that you ask whenever someone has double vision is firstly whether the double vision is still there if they close one eye. So this is differentiating monocular versus binocular diplopia or double vision. And so if the patient covers one eye like this and they still see double, that means that it's a monocular problem, which, for the most part, worries us a little bit less as ophthalmologists because typically monocular diplopia has a much smaller differential. And so typically the most common thing is because will be due to dry eyes, but any sort of corneal pathology can cause this as well. Or sometimes cataract, depending on how the cataract is forming, can cause monocular double vision as well. So the differential between monocular and binocular is very different. So that's why it's important to establish that as sort of the first step. The binocular diplopia is a bit more complicated because this typically represents some sort of problem with either the central nervous system, like inside the brain, or something with the peripheral nervous system, so related to the cranial nerves. And so that's why if you think they have binocular double vision, it's important to then go through all your extraocular movements, such as what was on the previous slide, to try to localize which cranial nerve you think is the issue. And we won't go into the details of how to test all the cranial nerves, but some of the highlights you should remember is that your cranial nerve 3, your ocular motor nerve, controls most of your extraocular movements, And if you think that's impaired, the main thing you have to rule out and the life-threatening thing, the thing that in your family doctor's office you could actually save someone's life by doing this, is if you think they have a cranial nerve 3 issue, this could be a sign of a posterior communicating artery aneurysm. And classically, we remember this as like a down and out and blown pupil. It's important that these patients are referred for an urgent CTA to make sure they don't have an aneurysm. Because once you start getting involvement of the oculomotor nerve, these aneurysms can be quite big and life-threatening if they rupture. Cranial nerve 4 has its own differential, which we won't get into here. And then cranial nerve 6 also has its own differential. But one of the key things to remember about cranial nerve 6 issues is that this can sometimes be signs of increased intracerebral pressure because the course of the 6th cranial nerve follows along the skull base. And so if you have high ICP, basically pushing your brain down, you can get impingement of the 6th cranial nerve, which can cause issues with your lateral rectus and your ability to move your eye out. And so some other important points about diplopia, if you see this in your clinic, is whether the onset was gradual or sudden. One of the key things and a very common cause of diplopia we see is a vascular cause, so microvascular ischemia to a cranial nerve itself, and that often results in a sudden diplopia. And the other takeaway that I'll mention is that if you get diplopia that kind of comes and goes and doesn't necessarily localize to a single cranial nerve, that can be signs of myasthenia gravis, Graves related to thyroid eye disease can sometimes cause this, and there's also a number of other causes related to orbital inflammation. And so all these conditions would warrant a referral to an ophthalmologist or a neuro-ophthalmologist, depending on what resources you have in your local center. And so one of the last points I wanted to leave you off with was, realizing that many of you are going to be practicing in settings outside of ophthalmology, whether that be family medicine, emergency medicine, internal medicine, things of that nature. And so, when you eventually see an eye complaint, I think it's important, if anything, that you take away from this lecture is, how to communicate with your friendly ophthalmologist on call and how to effectively communicate what you think is going on with your patient so that they can be seen appropriately. And so, some key points for submitting an ophthalmology consult is, I think, definitely doing those ocular vital signs that we mentioned, vision, pupils, pressure. Vision, try to correct it as best as possible, whether that be with glasses or a pinhole, which takes out the refractive error. And so, pinhole is really important because sometimes, you won't be able to have the patient's glasses and know if they're up to date. And pinhole basically allows you to, get rid of all those confounding factors and really get a sense of what their eye can see best from a refractive standpoint. Pupils is important. An RAPD can be a sign of a lot of life-threatening causes of vision loss, so it's important to check that. And then also pressure. And if you don't have a tonal pen, that can be as simple as just pressing on the eyeball. Extraocular movements is very important. As we established in that case with diplopia, it can sometimes be signs of a brain process going on. As we mentioned, it can also be a sign of a stroke, things like that. Confrontational field is also very important. It can help you discern whether you think someone has a field deficit, if you think they may have a retinal detachment. It can also be signs of stroke, things like that. And then the last two are kind of bonuses. If you have access to a slit lamp, that would be awesome if you can, give us a sense of what the eye looks like, and also fundoscopy. But, in most settings, you won't necessarily have access to those two last tools. And so really, if you can just do the first couple of things, that already gives us a ton of information about how severe we think the patient's complaint is and can help us triage them appropriately. And ultimately, I think the last point that I try to stress is that, most ophthalmology residents and ophthalmologists, realize that most people outside of our specialty don't see eye complaints very often. And so even if you don't remember all the technical terms for, RAPD and, the anterior chamber and all that sort of stuff, just try to describe what you see. And at least if you can get the vitals, I think that can give us a lot of information and that can be very helpful. And so I just wanted to end off with this. Best of luck with residency. I think it's such an exciting time transitioning from being a medical student to a resident. And although it comes with increased responsibility, which can be stressful at times, I think that transition is such a important transition in one's medical training, and I hope that all of you go through that transition smoothly. And all the best starting residency.